My name is Dr. Simcock, and I've worked in the medical profession for over 40 years. During this time, I've seen a great deal of change in the field of care of the elderly. When I embarked on my career, problematic old folk were shipped into wards, usually in the grounds of the local asylum. I remember going, as a relatively young medic, to some of those places. They could be pretty grim. Elderly patients lying in low cradles, or metal framed chairs made of nets, unable to move. Simple restraining techniques. You see, when people can't physically get up, they're stuck there. Sometimes all day. Today we like to think we're more sophisticated. This door, for instance, is locked. There is a key, so technically the client is free to leave. But in practice, only the staff have access to it. It safeguards against potential escapees. Of course, we still use drugs for any particularly difficult patients. The liquid cosh, they used to call it. There's been a big backlash against administering antipsychotics to the elderly. The chemical ball and chain. But why spend time and energy keeping an eye out for someone who is prone to wander, when effectively they can be tied in their chair with high doses of risperidone or haloperidol? Well, for a start, it can put some people at greater risk of having a stroke. When this hit the press, lots of the relatives started panicking about the side effects and asking us to take their loved ones off their medication. But it's not as simple as that. See, for a start, they have to be weaned of it. Well, in a short while, the agitation and anxiety would resurface. The relatives were straight back onto us, begging for it to be reintroduced. In some dementia care homes, they put mirrors on the doors. The mirrors distract the patients, or they'll wallpaper over exit doors. And that way it looks like a wall instead of a door. Then the patient doesn't even try to escape. Having said that, I have known cases of clients trying to escape from second-floor windows. Luckily, very few succeeded. It's all about risk assessment. You have to determine which is the lesser risk. Do we start letting people who are vulnerable to falls wander around the building if it makes them happy? What if they wander and they fall and break a hip? Whose fault is that? And more importantly, who is going to pay? Because at the end of the day, it's all about the money. Ideally, there would be one-to-one care for patients with dementia, but that's not going to happen. Diversion tactics usually works best. Distract the patient, give them another focus, a task. Stop them focusing on the negative. Dementia patients often get preoccupied with going home, even when they are home. They get caught in a cycle or loop of behavior, often relating to past experiences. I've known clients trying to escape from second-floor windows. Luckily, very few succeeded. And what if they wander? It's about risk assessment. What if they fall? Break a hip? Whose fault is that? And who's going to pay? And ideally, there would be one-to-one care for patients with dementia. I just wonder, do you have a key by any chance? I have to be in the surgery in half an hour.
Come on, John, I'll make you a nice cup of tea.
Dr. Simcock.
Sorry, Dr. Simcock.
I need to leave. I've got to be in the surgery.
Oh, well, I'll call the surgery and let them know you'll be there soon.
But I like to arrive early.
Well, even doctors need a tea break.
Well, seeing as you put it like that.
Come on, we'll get you a cup of tea and I'll find your trousers.
And then I can go back to work.
Oh, of course you can.
Excuse me.
Yeah.